sharing the slide set at your end and see if that becomes visible.
Sir, I think we are now live. It is showing webinar is now streaming live. Yeah, I think it is live.
So we can go ahead.
Yeah.
So are the slides visible on? Is it streaming?
Yes.
Can you see the video?
I just
can you see the slides? Okay.
Just confirm it.
Shall I?
No, sir, it's not there.
It's not there.
No.
On Zoom it is showing. Zoom पे दिखा रहा है, but it is not coming there.
But
Find you shared the Zoom link with the audience, or you've shared the YouTube link with the audience?
We've shared the Zoom link with us only. Zoom link is with us only, with you and us, but the attendees have a different link. So that is the issue. Okay.
Neerav, try to share your screen. I'm stop sharing, and you try to share your screen in the slide set. You also have that with you. Neerav, do that.
But sir, problem is something different.
Yeah, I know. Now they are saying webinar is now streaming live on YouTube. Now I can see that. Check it now.
Sir, I am on the other end. My mobile is there, and I am checking it.
Can you see it now?
It is not
Is
there.
the audio there?
No, nothing is there, sir.
Are you streaming it for as a subscribe channel? I mean, I would like to know if you're
yes,
doing
sir. Actually, it is the netcast channel for mankind. So
फिर तो क्यों नहीं हो रहा है? You must have paid it to the YouTube guys, right?
Yeah.
Yeah,
it is also showing live to us.
अच्छा होता है कई बार.
क्या issue आ रहा है? Can we?
What's the issue if somebody can tell?
सर हमने इसको लाइव कर दिया है, खाली सर्वर पे वो लोड हो रहा है, जस्ट थोड़ा सा टाइम लगेगा, फिर लाइव हो जाएगा वो.
Okay.
लाइव होगा अगर टाइम डिले के साथ होता तो I can start it. That's what I'm saying.
अच्छा गौरव जी एक बात बताइए, if अगर हम YouTube का लिंक लेके शेयर कर दें, will it be okay? Can we share it to our audience? Because YouTube पे I'm able to see now. मैंने YouTube पे लिंक किया है तो वहां पे आ रहा है.
Screen आ रही है?
हाँ, वहां पर sir you are visible and even the screen is visible.
Yeah. So then share that link. Now, what's the problem?
Yeah, we'll share that link, right?
Yeah, forward the link, Neerav, to those, and then I think we can start again.
Right. Yeah, I can see that. Yes, it is showing started streaming.
So I'll start now. Ritesh,
what should we do?
I'll go ahead.
Ritesh, are you there?
There is one more way. You can record the session here and upload it later on.
No, sir, just allow us next 2 minutes. It's this issue is about to got solved. Just give next 2 minutes. Will not take more than that.
Sir, we can start now. Now, Nirav ji, I think अब okay. Sab okay, sir. We can start. Thank you. Thank you. Yeah.
All
Yeah,
right. So
yes.
there were some post resolving of the glitches that were there at the end, technical glitches. I'll go ahead. My screen, I hope, is visible now. So I was saying that we are going to discuss how the other NOACs are in a different group as compared to rivaroxaban, because when you look across the spectrum, rivaroxaban has got indications and therapies which are proven and evaluated in chronic cardiac syndromes, cardiac post-MI, CADs, PVDs, AF post-PCI, even for patients with renal failure and DVT and PE. So the 2.5 milligram BD with rivaroxaban with DAPT is acceptable and evaluated in COMPASS trial, which is not the case with dabigatran apixaban. And the dosaging, of course, 20 milligrams or 15 milligrams is for AF. 10 milligrams you can choose optionally with P2Y12 inhibitor post PCI. Usually 15 is what is preferred, where you would discontinue aspirin. And in renal impairment, of course, 15 is the dose. DVT prophylaxis, the dose is 15 milligram BD for 21 days, followed by 20 milligrams per day or 10 milligrams per day. This is because primarily true OD dosaging because of the high plasma protein binding, which is 95%. And that's why dabigatran and apixaban, even a single dose missed, can actually play havoc, especially in patients with AF. And that's why truly OD dosaging actually increases drug compliance and actually gives benefit in real world scenario to this molecule. So rationale for using in cardiovascular protection is because of the residual risk despite the optimization. Even when you have high risk patients post ACS, which is beyond a year, in these subgroup of patients, the lower risk continues to be there despite aspirin, statin, and ACE inhibitors and beta blocker, etc. And this is driven primarily because the incidence of MACE, according to history of the ischemic events, in patients with stable atherosclerotic disease without ischemic event at baseline, it continues to be high as compared to those who have just the risk factor without a previous event. So though this is slightly lesser as compared to those who had a ischemic event at baseline, stable CAD patients would still have events more than those who just have risk factor. And this 4-year incidence of MACE, and this is from the registry data, which talks about the ischemic event rate to be 18.3% if there is a prior ischemic event. So despite guideline recommended therapy, patients with previous events are at high risk of occurrence of recurrence of events. Now, holistic approach would be to not only provide cardiovascular protection, but also protect from other atherosclerotic disorders, which include stroke and peripheral vascular disease. So hence the concept of vascular protection rather than just cardiac protection in patients with atherosclerotic disorder is the prime importance. So you not only need to control CV risk factor to limit atherosclerosis progression and stabilize the existing plaque in form of lifestyle changes, which include smoking cessation, regular exercises, healthy diet, weight and psychological support, statins, ACE, ARBs, and insulin or antiglycemic, or now the SGLT2 and GLP-1 analogs, which are important medical therapy for CV event reduction in these subgroup of patients. You'll also have to look at prevention of blood clot formation over any ruptured eroded plaque, because these patients harbor a lot of unstable plaques. And we all know that the most of the acute MIs are caused by non-critical plaques, which are actually thin fibrous plaques, which can rupture and cause a sudden platelet aggregation and cause sudden occlusion. So the single-ended platelet therapy with aspirin or clopidogrel, compared to that, when you combine it with thrombus burden prevention by the therapies like rivaroxaban, you can actually prevent progression of thrombin generation in contrast to previously following elevated ACS patients with adverse outcome. So thrombin is the most potent stimuli of platelets. You just don't want to block the platelets. You also actually want to prevent the thrombin to come into the platelet activated ruptured plaques and cause complete occlusion. And that's why blocking 10A inhibition of thrombin from both extrinsic and intrinsic pathway, apart from platelet inhibition, using rivaroxaban is an important strategy. Theoretically, that's how this whole thing was proposed. Now, the platelet activation has got two positive feedback loops. One that comes from the platelet itself, and the other that comes from the thrombin itself. So thrombin made on platelet surface can trigger further most platelet aggravation, while ADP secreted platelets can be blocked by the and thienopyridines. So blocking both separate pathways, the antiplatelet pathway and the thrombin pathway, is a good strategy of blocking both pathways to have another event coming in. So rivaroxaban affects not only fibrin formation, but also platelet inhibition, which is another mechanism that has been ascribed to this molecule in management and prevention in chronic cardiac syndromes. So ACS patients, of course, we know that DAPT is the recommended therapy according to the guidelines, and rivaroxaban vascular dose along with DAPT is an alternative. Now, significant reduction in CV death and all-cause mortality in secondary prevention of ACS in acute phase is an important strategy. But what is important is to find a guideline-like patient or a trial-matching patient or a right patient whom to put on the so-called triple therapy, as we know. So with increased ischemic risk, there is elevated risk of cardiac biomarkers versus without increasing bleeding risk. That is the other subgroup, that there is no history of TIA or stroke or no recurrent or recent evidence of any major bleed, especially GI bleeds, because that's more rampant with the rivaroxaban as compared to the other NOACs, though most of them are non-fatal and non-life-threatening. And it is sometimes also mentioned that actually this therapy picks up hidden cancer in the GI tract because of bleeding that may actually bring out a cancer much earlier from the GI tract as compared to the patients who are not on this therapy. And of course, the creatinine clearance has to be more than 30 without other anticoagulation. We have to be very cautious when the creatinine clearance is between 15 to 30. So when you have a patient with increased ischemic risk, that's their elevated biomarker, multivessel disease, diabetes, dyslipidemia, versus without increased bleeding risk. That means they never had a bleed, they have a good BMI, their creatinine clearance is good, and the hemoglobin is more than 12.8, which was the mean hemoglobin in the Compass trial. In the subacute treatment follow-up, weighing the individual patient risk for ischemic and bleeding events, combining 2.5 milligram of rivaroxaban with aspirin and clopidogrel for 12 months was a good strategy. And this data comes from the Atlas trial, actually, where we know that rivaroxaban vascular dose reduced CV events and death in patients with ACS. And the Atlas trial with the recent ACS actually shows that CV death, MI stroke is reduced by this therapy by 16%, cardiovascular death by 34%, and all-cause death by 32%. And these are in terms of course relative number. The net number to treat ranges from 60 to 70, 63 to 71, which is not a very big number because you just need to treat very few patients by this therapy to prevent one event. So rivaroxaban for secondary prevention for ACS, of course, in the chronic segment, when you look, is to be given along with aspirin or with aspirin plus clopidogrel as indicated in atherosclerotic adults with ACS with elevated biomarkers. The 2.5 milligram BD dosages along with 75 milligram aspirin and 75 of clopidogrel. It's recommended at least 24 months. Patients with after ACS, they continue to be at risk for cardiovascular event, and therefore it can be extended for treatment once you initiate them on this therapy. So this is from the European Commission, which had approved it based on the Atlas data. And Atlas to me actually showed that in patients who were on higher dosages, had more GI bleeds, though there were definitely benefits in terms of occurrence of CV events, but the higher bleeds actually nullified on the higher dosages, and that's how the 2.5 milligram dose was discovered in the Atlas trial to be beneficial for patients for preventing the dual pathway inhibition, as it is called. So vascular protective strategy for secondary prevention in the Compass trial looked at the MACE rate, stroke rate, MI and death rate, where lipid lowering was by 21%, BP lowering of 1 millimole, which is like 38 milligram percent of reduction in the lipids, would result in 21% reduction, ACE 22%, 10 millimeters of blood pressure reduction by 20%. But look at the Compass trial. When you just add rivaroxaban 2.5 BD with aspirin 100 milligram, you reduce by 26% MACE rate. And most astounding results have been found in stroke reduction, which is more robust than either of the three strategies where you do a lipid lowering or BP lowering or ACE lowering. When you add patients with rivaroxaban on top of aspirin, in Compass trial, stroke was reduced by 44% and death was reduced by 23%. And this goes on to show how, just like statins or blood pressure lowering or ACE inhibitors like HOPE trial, benefits of dual pathway on top of standard care should be used in the overall vascular protective strategy. Now let's compare some of the trials in patients with stable coronary artery disease and or peripheral vascular disease. These are the trials which have been done so far in stable coronary artery disease. We often find a lot of patients on dual antiplatelet, clopidogrel, aspirin. A lot of patients are given dual antiplatelet in patients who don't have ACS. But this is from the Capri, if you look, or even you look at the Charisma trial, though the MACE may was reduced was slightly, but there is no significant benefit in terms of mortality in any of the trial. So clopidogrel plus aspirin in patients with stroke MI or symptomatic peripheral vascular disease, though MACE is reduced by 17% and there is no increase in the gustosevere bleeds, but this did not result into mortality benefit. If you compare even it in Capri trial, it's just 9%, very small reduction. Again, bleeding was not significantly improved. So Capri was a comparison between clopidogrel and aspirin, while Charisma actually compared clopidogrel plus aspirin up as compared to aspirin alone in Charisma, and it did not show any bleeding increase with a small reduction in MACE, but no benefit in mortality. The recently one more trial with Pegasus, which is of ticagrelor 60 milligram beyond a year, was also evaluated in patients who had previous transmural MI or had high CV risk. It reduced 16% relative risk reduction, just like Charisma, almost the same, but with twice more than 2.3 times higher major bleeds. So you had benefit again, and the benefits were nullified by the bleeds, and again, no mortality net benefit was found. Voraproxar, which is a new anti-platelet drug in the NOAC pathways, which is actually looking in the TRA secondary prevention TME50 trial on top of aspirin with or without thienopyridine in patients, reduced 13%, but bleeds were increased by 1.7. Now compare this with Compass, which reduced the MACE rate by 24% and also modified the bleed risk increase by 1.6 times, but there is a reduction in mortality. So if you have a mortality reducing therapy, it would outweigh any other therapy. So good option would be to choose rivaroxaban with aspirin rather than clopidogrel, ticagrelor, or Voraproxar. So Compass basically looked at two things. The trial actually had three arms. One was rivaroxaban 2.5 BD with aspirin 100, or aspirin alone, or rivaroxaban 5 BD. And they included patients who had age more than 65, or they had age less than 65, but at least two bed involved, means either PVD or coronary artery or carotid disease, apart from prior MI, multivessel or multivascular events, post-CABG, post-PCI, or multivessel disease. And the additional risk factors were smoker, diabetes, renal dysfunction, heart failure, non-ischemic stroke more than 1 month back. And it excluded patients on DAPT other than and eGFR less than 30 and severe LV dysfunction EF less than 30%. But you can see that when you combine this beyond a year in patients with aspirin with rivaroxaban 2.5 BD, major adverse events were reduced significantly, MACE by 24%, stroke by 42%, and more importantly, death by 22%. As compare this with the bleeds were slightly high, which is modified IST major bleeds, with hazards of 1.7 without any increase in fatal or non-fatal IC bleeds. So most of these were GI bleeds, which can be managed and they are more easy to manage as compared to intracranial bleeds. So chronic cardiovascular disease, who derives the greatest benefit for Compass, are those patients who have multiple comorbidities. So as you go on increasing risk, like CAD plus PVD is one group. When you have peripheral vascular disease, coronary artery disease, you prevent 60 events over 1,000 patients over a period of 2.5 years, as compared to diabetics, where the events prevented are only 31, and overall population it's only 23. So heart failure, renal impairment, as the number of risk factors go up, you actually end up preventing more event rates in these subgroup of patients. Again, polyvasculopathy, as it is called, is mild to moderate heart failure, CKD, and diabetes. When there was none risk factor, the difference was very little. But as the number of risk factor increases 3 to 4, the curves separated even more. So more the riskier the patient, more is the events prevented when the dual therapy, dual pathway inhibition is chosen. So 2019 guidelines for chronic stable CAD now talks about adding as a second antithrombotic to aspirin for secondary long-term prevention in high-risk ischemic patients without high-risk bleeding as class 2A level of evidence A indication for adding rivaroxaban as 2.5 milligram BD in the vascular dose. As a second antithrombotic for a moderately increased risk, also it's recommended as 2B. So high ischemic risk is now defined as diffuse multivessel disease with at least one, which is either diabetes or past MI, recurrent MI, peripheral vascular disease, or CKD. And moderate is defined as diabetes requiring medication, of course, multivessel disease, recurrent MI, PAD, CKD, and you add heart failure as one more here amongst any one of them. So dosaging, as we all know, clopidogrel, prasugrel, and rivaroxaban, however, 2.5 BD is beyond a year for multivessel, and ticagrelor is 60 milligram BD. So let's come to the critical analysis from Dr. Kelkar's paper, which was published in Indian Heart Journal about COMPASS in Indian context. And the critical analysis showed that though there were very few patients from India in the COMPASS trial, but this analysis looked at how the younger age group appeared to derive greater benefit from this combination, as seen with the net number to treat metrics as compared to the older group. And the decision to prescribe in India to a young patient, which we are otherwise a young country with less than 65 years, should be considered as an option, as the disease is already seen a decade earlier as compared to other countries in our part of the world. So COMPASS regime is the first long-term antithrombotic regime apart from aspirin, which reduces mortality. You have rivaroxaban aspirin, MACE reduced by 24%, stroke 42%, MI 14%, though 70% increase in bleed and death is reduced by 18%. This is on top of what ASA trial of aspirin had shown, as we all discussed. Aspirin with ticagrelor, aspirin with clopidogrel alone did not reach a statistical significance. So secondary prevention for PVD, as we must know that CAD patients have almost 1/3 or nearly 1/4 to 1/3 of the patient will have peripheral vascular disease. Only 10% of atherosclerotic PVDs don't have coronary artery disease. And that's why I always say, for a cardiologist, if you're doing a peripheral angiography and patient is more than 45 and you're suspecting it to be atherosclerotic peripheral vascular disease, it's a must that you do a coronary angiogram. That's how an interventional cardiologist differs from a peripheral vascular or interventionist. Because CAD, when it's present in 90% of the patients, CAD only 72%, but once you have a PVD, 23% I have had both of them, and only 9% had only PVD without CAD. So just like multivalvular patients undergoing a coronary angiogram before valve replacement, I think peripheral vascular disease in an elderly patient should also have a coronary evaluation done. So atherosclerosis is a polyvascular disease with substantial patient overlay, both between CAD and PVD. 25% patients with CAD had disease in other vascular beds. For a four-fold increase in the fatal MI in these subgroup, 3-fold increased risk of cerebrovascular stroke, and 61% of patients with PVD had disease in other vascular bed, which is majority of them. And that's why in REACH registry also, which is published in Deepak Bhatt's paper in JAMA, it tells you that you should be very suspicious of other bed involvement if you have peripheral vascular disease patient. So current treatment strategies for PVD would be exercise training, cilostazol, stent placement and revasc, and lifestyle modification with statins, ACE inhibitor, diabetes control, antiplatelet, smoking cessation. And on top of that, in chronic PVD now we have data. When you look at Capri data subgroup, Euclid trial from ticagrelor, and now you have Charisma subgroup with clopidogrel, which talks about high residual risk of CV and limb ischemia despite the high guideline guided therapy. So clopidogrel in symptomatic PVD reduced MACE by 24%, but ticagrelor versus clopidogrel, there was no additional benefit, while clopidogrel with aspirin did better by 17% reduction. But PAD patients are vulnerable because of high risk of limb amputation and also with coronary events. So acute post-phase revascularization in the stable phase also, there is 4 times higher risk of acute limb ischemia in compared to those who don't undergo revasc. And major limb amputation can also arise. So median hospitalization in patients with acute limb ischemia is almost 8 days, with 4% die at the time of presentation, 20% will end with amputation, 1/3 will have prolonged ICU stay, and 3/4 will require a major surgery. Hence, outcomes after hospitalization are very poor, with 15% are disabled or dead. So high risk, but few proven strategies that can be used, that there is no proven antithrombotic strategy that has demonstrated efficacy to reduce limb ischemia or CV events after peripheral revasc for ischemia. There is index grust of occlusion, revasc, need for revasc replacement, major amputation or death as a combined endpoint. It showed that despite DAPT, you give aspirin and clopidogrel in patients who have undergone revasc, there is no difference. And even in full intensity anticoagulation, there is increased risk of hemorrhage. So bleeding increases when you add drugs to aspirin in patients with pure PVDs. So what you need to do is add rivaroxaban. Rivaroxaban 2.5 BD will, again, as I said, block the PAR4 and also inhibit the platelet to some extent, which is activated through the thrombin pathways. And this synergistic target, hence will prevent further worsening. And this was again DPI with rivaroxaban 2.5 BD with aspirin reduced the MACE rate by 28% and limb ischemia rate by 46% versus aspirin. So even in peripheral vascular disease, 33% reduction in MACE or MALE, including major amputation in PVD patients was documented with rivaroxaban aspirin significantly reducing major amputation by 70% as compared to aspirin. So as I mentioned, despite the three important trials being negative, the Capri, Euclid, and Charisma, no place for clopidogrel or ticagrelor apart from aspirin getting major benefit. But with rivaroxaban in COMPASS subgroup, you can see though the bleeding increases by 1.6 times, just like clopidogrel added to aspirin. So the bleeding risk is just like aspirin plus clopidogrel, but benefits are much, much more important, like 28% reduction in MACE rate, and limb ischemia reduced by 46%, and amputations reduced by 70%. Hence, PVD patients should be prescribed dual pathway inhibition apart from aspirin. And this is what the new guidelines recommended from 2017, actually, that the asymptomatic versus symptomatic lower limb ischemia, no SAPT is class 3A, of course, single antiplatelet was 1A, but in patients with dual pathway with clopidogrel has now been changed, that in 2019 guidelines talk about adding rivaroxaban with class 2 level of evidence B to reduce adverse events and lower extremity ischemia in patients with chronic thromboembolism, limb ischemia. So rivaroxaban is the way forward. As I said, in patient with the long-term secondary strategy prevention, we know that SGLT2 molecules like empagliflozin, they reduce death by 32%, PCSK9 by 15%, EPAs, which has been reduced in trial where they reduce by 13%, colchicine increases mortality by 21%, despite reducing MACE by 31%, which was primarily driven by reduction in MI and stroke, but higher death rates, and hence colchicine can't find a place. But the rivaroxaban is all in favor. It reduces stroke, death, and MACE rate, including MI rates. So Voyager PAD trial was the another trial which looked at the limb ischemia rate or major amputation, as the MALE as it is called, with a significant reduction, with net number to treat at 6 months being 65, as compared to 50 patients only at a year, with only 39 patients requiring benefit at 3 years. So 3 years of therapy, you need 39 patients to be treated to prevent chronic complications of MALE, as I said, for the reduction in the event rates. So Voyager PAD actually showed that whatever outcome you were analyzing, including VTE, were significantly reduced, except mortality. Either components individually or clubbed together into groups were cumulatively reduced with significant numbers in all subgroup except mortality. So Voyager PAD is the only randomized large trial to show significant CV and limb benefit after PTA or PABG, a peripheral bypass or peripheral angioplasty. So Mirror trial, Camphor trial, Casper trial, Dutch trial, all of them have shown that it increases bleeding when you add clopidogrel or VKA to aspirin, with the trial stopped for clopidogrel aspirin because of infrainguinal due to poor recruitment. But Voyager, with moderately severe symptomatic PVD undergoing revas, your superior reduction of 15%, acute limb ischemia reduced by 33%, hospitalization by 28%, and urgent need for another revas by 12% in patients who are discharged on rivaroxaban. So for acute intervention to long-term safety, rivaroxaban 2.5 with aspirin reduces the risk of major adverse events, reduces MACE, reduces MALE, less amputation, less hospitalization, and less chronic vascular hospitalization as well. And this is, so once the acute phase is over, of course, the COMPASS takes over. So you can actually go, and COMPASS data evolves over a lot of years. Voyager PAD is for the acute, COMPASS is for chronic. So we know when do you start dual pathway inhibitor? Right at the post-revask. After, once the hemostasis is achieved, say 7-10 days, you can start the patient on 2.5 milligrams of rivaroxaban. In vascular clinic, in COMPASS, in chronic stable PVDs, also in high MACE risk groups like diabetes or EGFR between 15 to 60, or heart failure EF more than 30, or patients who have chronic limb ischemia, smoker, or prior revask or amputation, they can also be started based on this. So there are multiple opportunities to enhance vascular protective antithrombotic therapy in patients with PAD, 75-year-old coronary artery disease, 62-year-old female worsening symptoms, 55-year-old with ABPI less than 0.9, which is associated PVD, post-revasc amputation in elderly male, claudication in 57-year-old, diabetic in 60, all a high-risk group of patients because they have two risk factors. So once you have understood the chronic therapy for stable dosages, there is a substantial subgroup of patients who have also atrial fibrillation. Now, 2 to 21% of ACS patients may present with atrial fibrillation, in which case the dosaging cannot go with the same. You will have to switch to rivaroxaban 20 milligrams. So stroke prevention AF is mandatory approach, and the 2020 guidelines for AF along with EACTS with CHAS-VAS2 score is recommended for stroke prevention. We all know CHAS-VAS scoring. In anybody who's got 1 and above, you actually think of NOAC as the therapy, and more than 2, of course. You can choose LA occlusion devices if the patient is contraindicated to the therapy. Otherwise, NOACs are class 1A indication, where oral anticoagulant of the amongst all of them can be chosen in preference, with antiplatelet alone being harmful. So AF undergoing PCI for NSTMI, the default strategy is to start triple therapy, that is aspirin, P2Y12 inhibitor, and a NOAC. And this you will give at least for a week, and then you can discontinue the single antiplatelet, which usually is aspirin, and you can continue with one antiplatelet and add NOAC to it. Sometimes in patients who are high risk bleeding, you will have to actually switch to single antiplatelet, dual antiplatelet therapy only up to 6 months, and beyond 6 months, you can go on NOAC alone. In high ischemic risk, however, you'll continue triple drug for a month and then go to DAPT beyond a month. So you can strategize according to HASBlood and CHAS-VAS2, and default strategy being up to a week of triple, and then beyond a week, you can go with the dual strategy for a 1 year and NOAC alone after that. So NOAC dosaging in non-valvular AF is pretty clear, and I need not be repeating this. 20 and 15 for rivaroxaban, 5 and 2.5 BD for apixaban, 150 BD for dabigatran, and 110 BD for dabigatran for low dosaging in those with kidney alteration. Of course, the criteria for low dosages are pretty well defined, which includes, of course, the eGFR and the elderly patients who are at risk of bleeds. When you look at the CHAS-VAS2 between Rely, Aristotle, and Rocket AF, the 3 trials of the 3 NOACs, you can see that the highest CHAS-VAS score was there for rivaroxaban. So as you go towards the CHAS-VAS2 in patients with trials with rivaroxaban, AF patients with Rocket AF had higher risk of stroke than patients in other phase 3 trial, and hence the strong correlation with HASBlood score has found that dabigatran and apixaban have been evaluated across a spectrum of stroke risk, where rivaroxaban is evaluated even higher stroke risk group of patients. And we all know that how the scoring is done. You can see that almost 55% of the patients who already had in Rocket AF prior stroke or TIA, which is more than 3 or 2 times, 2.5 times as compared to dabigatran or apixaban trials. So AF patients were studied mostly in Rocket AF with higher doses of stroke than patients in other 2 NOACs. And that's why the trial summary would be interpreted in light of that, that despite that high incidence or high risk patients, the event reduction was as efficacious as the other 2 trials where they looked at the apixaban or dabigatran with Rocket AF, including the sickest patients, and 17% population already had prior MI, and the trial population hence were different between all the 3 groups, and that's why Rocket AF should be interpreted in that light. Rivaroxaban has proven its safety and efficacy by the OD dosaging in antagonism and stroke and embolization. This is a paper published in 2011, which talks about how it prevents systemic stroke by 21%, hemorrhagic stroke by 41%, and non-CNS systemic embolization by 77%. And there is also a trend towards decreased MI and overall CV outcome. The net benefit is much greater in the elderly. So in elderly, all-cause mortality, non-hemorrhagic stroke, and life-threat bleeding were more significantly found to be efficacious with rivaroxaban arm. The prevalence of AF and CKD both increased with the age, and every 3rd patient with the development of AF has actually CKD, and that's why in these subgroup of patients, it's important to choose this therapy. EHRA guidelines, use of NOACs according to the renal function. It's pretty clear that it's only and only with rivaroxaban that you can use it in 15 to 30 dose that is not different as compared to the other molecules, which is 15 milligrams OD, while in dabigatran is not approved with eGFR below 30. You can choose edoxaban, which is not available, and apixaban, which is 2.5 ED. Otherwise, of course, the criteria, there is no recommendation in patients with less than 15 or on hemodialysis. So there are a lot of the trials have actually, Rocket-AF had a specific renal arm, which was not the case for the Aristotle or Rely, and the number of patients on dose, low dose of moderate renal infection was 20% in Rocket-AF, and you can hence say that rivaroxaban is the most studied NOAC in that subgroup of patients. So dose adjustment is recommended in renally impaired by based on eGFR. If the eGFR is less than 15, you don't recommend a rivaroxaban. Between 15 to 50, 15 milligrams, and beyond 50, you go to 20 milligrams. While it's more complex with dabigatran, it's only 30 that you can choose. Above 30 and above, you can choose, and then you have to, of course, put on the criteria of age in both the subgroups, check at the age, check at the features in apixaban, which is more complicated. With rivaroxaban, it is pretty simple. Just look at eGFR and you can choose the dose. Rate of stroke and systemic embolization with moderate limb impaired receiving a reduced dose of NOAC versus warfarin clearly shows that it favors all the three. In the NOAC arm, but 1 year outcome associated with reduced dose of NOAC in renally impaired patient with apixaban actually favors warfarin. And this is from where people talk about choosing warfarin rather than apixaban in patients who are in AF in long-term strategy. But with rivaroxaban, that's not the case. Neither is the case with dabigatran. But apixaban has a signal more in favor of ischemic stroke, in favor of warfarin in the patients with renal impairment. So NOACs have shown benefit risk profile versus warfarin in non-valvular AF. Meta-analysis of phase 3 trials show that 19% reduction in stroke, 52% reduction in ICH, 14% reduction in major bleed, but 25% increase in GI bleed. So the relative efficacy safety of NOACs are consistent across a wide spectrum. The AHA HRS focused update of 2014 was updated in 2019, and it recommends that they are recommended in preference of VKA as class 1A recommendation. Prevention of thromboembolism, again, it's 2A for based on the CHA2DS2 of 1 in men and 2 in women. And formal risk-based assessment for HAS-BLED is recommended as 2A level indication. For thromboembolic events, antiplatelet therapy alone is harmful. Don't rely on DAPT or SAPT or just aspirin alone. They are hazardous. There is estimated bleeding risk in absence of contraindication of NOAC should not in itself guide the decision to use NOAC for stroke prevention, and clinical pattern of AF should not condition the indication of thromboprophylaxis. Hence, protecting the challenging VTE patients. Now I'll touch upon, this is the third and the last segment of the talk. We all know that venous thromboembolism is reduced by usages of NOACs. You had RECOVER trial with dabigatran, Einstein trial, DBT arm, and the PE arm for rivaroxaban, Amplify trial for apixaban. And you can see that Einstein DVT was the most profound data with 0.68 of hazards ratio, which is 32% risk reduction as compared to the warfarin arm. So who do you consider as the most challenging patient? This is a fragile patient, active cancer patient, renal impairment patients, or young patients. So these are defined as the high-risk group of patients. In the chest guidelines for VT and no cancer, long-term anticoagulation, NOACs were considered as ahead of VK. For VT and cancer, again, first option in cancer with VT with low risk of bleeding and no drug-drug interaction. Again, it's the first line. So there is a gap in the guideline and additional research is required according to the age group. Rivaroxaban has consistent efficacy results across the most challenging population, whether you look at the fragile group of patients and the recurrence of the DVT, or you look at the cancer patient, or you look at the young patient profile or renally impaired patient profile. The Einstein pool data, overall VTE though was not different, but when you compare versus the standard care, rivaroxaban fared better even in all the 4 subgroups, though renally impaired patient, the pool data did not have much difference, but in young patients, cancer patients, and fragile patients, rivaroxaban did much better than the standard care. Rivaroxaban also has consistent safety results across these subgroup of patients, and the pool data was, of course, in favor of the same as compared to the low molecular weight heparin. And you can see that against the low molecular weight heparin, there was lesser incidence of bleed in fragile patients, and the trends were similar in cancer subgroup of patients. So it's best studied in Y spectrum. The pooled patients had 791 fragile patients. It also had 332 renally impaired patients, of which Zalia trial also looked at 101 renally impaired patients. In Select D, Einstein pooled and Zalia, they looked at the active cancer patients with 203, 354, and 146 patients active, respectively. And Einstein Jr. also looked at the children with less than 18 years of age, where the placeholder patients were looked into, and 333 and has got good data. So significantly reduced major bleeds in the fragile and elderly patients with 73% relative risk reduction. In patients with DVT, the rivaroxaban dosaging is 15 milligram BD for 21 days, followed by 20 milligram OD or 10 milligram OD with single drug approach. With apixaban, 10 milligram BD is required, rivaroxaban 15 BD is required for 21 days. And patient has already received, then you can continue intensified dosing of a total of 7 days of apixaban or 21 days of rivaroxaban. So to summarize, anticoagulation has progressed exponentially in last 20 years. Rivaroxaban, apixaban are factor 10 inhibitors, while dabigatran is a direct thrombin inhibitor. Rivaroxaban, apixaban have got low renal clearance as compared to dabigatran. It's the only NOAC to be approved in India for secondary prevention of ACS, chronic CAD, and chronic PVD. Rivaroxaban is only NOAC to be tested prospectively in renal specific dosages. The other data are retrospective and non-specific and small population. Evidence of preservation of renal function with rivaroxaban is now reiterated by the ACC/AHA focused updated guidelines, and rivaroxaban and apixaban are the single drug approach in DVT. Dabigatran requires bridging from the low molecular weight heparin, which increases the pill burden with apixaban, and hence the initial choice of ET. Rivaroxaban once a day makes it the ideal therapy to choose. Thank you very much. I'll be pleased to answer the questions if any.
Thank you so much, sir, for that enlightening talk. Sir, we've got a couple of questions. So should I ask them right now? Should we take the questions?
Yeah, please go ahead.
Okay, sir, for one question, I think we have got that if you look at 2.5 mg dose, is COMPASS trial the only trial where 2.5 mg has been studied, or have there been other trials as well?
Can you repeat the question?
Sir, basically the question is asking that is COMPASS trial the only trial with 2.5 mg?
So Atlas actually looked at as a subgroup. Atlas TIMI actually started with 10 milligrams. And in Atlas TIMI, however, the patients were acute coronary syndrome. They were not chronic CAD. And in the 10 milligram dosaging, there was increased incidence. The benefits were nullified because of higher bleed rates. Only 2.5 was showing a trend in benefit. And that's how rivaroxaban 2.5 in acute coronary syndrome, as was shown in the slides, is now recommended as a therapy in high potentially risk patients. So in the West, though the guidelines are not still allowing the same, but in India, it's allowed as an approved therapy. You can choose 2.5 milligram in acute setting, also apart from DAPT, with a potential risk of higher GI bleeds, but with decreased event rates. That's the only other trial which has used 2.5, but in chronic segment, COMPASS is the only trial.
Right. Sir, and what about Voyager PAD? I think this question actually is coming from me only. So Voyager PAD also, the BID dosage was used.
Yeah. So if you're talking about 2.5 across the spectrum, then there are other trials. If you're talking about coronary, then the COMPASS is the only trial. If you're looking at the PVD perspective, then yes, Voyager PAD is the other trial which again looked at. So you can call Voyager PAD as a Atlas equivalent of PVD. Again, it was looking at the acute settings, acute limb ischemias, which were post-revasc beyond 10 days, and then you were putting them on dual pathway inhibition, and how the limb ischemia and limb revasc requirement, or MAIL as it is called, major adverse limb events, were reduced by dual pathway inhibition as compared to the single pathway or VK pathways. So the other trial which looked in the PVD subgroup or peripheral arterial disease subgroup was the Voyager PAD, as you mentioned correctly.
Right. Sir, one more question we've got from Dr. Kirit Kubawat. He's asked that, do you need to stop rivaroxaban before a COVID vaccine? So the question is, before a COVID vaccine, do we need to stop it?
Yeah, fantastic question, because I think I hope that's the case with everyone, because everybody is receiving more calls about can they take vaccine rather than, sir, how do I treat my acute MI? So same has been my case. I've been getting frantic calls, and it's because of the confusion that has arisen, because those on blood thinner should not take kind of a guideline. And then again, people again talking about, the data being highlighted in media that there is increased tendency of clotting. So patients, everybody's so confused about it. I think with regards to vaccination, it's more hazardous if you're taking it for atrial fibrillation to stop the drug. If you're on AF, and that's why you're taking, it's more hazardous. There is no increased tendency of clotting or bleeding is the only issue that sometimes is there. In the current guidelines, if the INR is higher, if you're a high Hez blood patient, you can skip the dose on the day of vaccination is all that's recommended. In patients on VKA, however, if the INR is more than 2.5 or 3, especially more than 3, then probably you'll wait and watch till the INR comes down to 3, but below 3. But as I say, this is new terrain, new foray for everyone. Nobody knows very clear cut. There are no guidelines. You'll have to individualize the case. So whenever I get a call, I always tell them that either you should go and meet the doctor nearby, or you can come over and I'll have a look at you. I cannot tell you on phone whether it's okay to take or not to take the vaccine, because it will have to be individualized till there are clear-cut guidelines about anticoagulation. So in patients who have had a high ischemic burden, I would not discontinue it in the vascular dose. In AF, again, there is a risk if the patient ends up with a stroke by skipping the dose. Again, it's hazardous. But if the patient is on VKA, then probably, and the INR is more than 3, then it's wiser strategy to stop it a couple of days till the INR comes below 3 and then give the vaccine. Otherwise, with the already ongoing talks about increased risk of clotting with one of the vaccines, it would not be a very wise strategy to discontinue it for like a dental procedure or GI procedure and then go for a vaccination. So that's how I look, but I think it's completely individualized. You need to see the patient, decide based on his CHA2DS2 or his Hez blood tendencies or his risk profile to whether to stop it or not to stop it. But as far as I am concerned, I usually don't take it off unless it's in a chronic segment.
Right. I think, thank you so much, sir, for the answer. One last question. I think this question is repeated throughout all the CMEs we have conducted. Sir, DAPT versus DATT, which do you see having a more or greater bleeding risk? Where do you see bleeding risk being more?
Okay, so it depends on what you're looking at and what phase of subgroup you're looking at. If you're looking at, say, the data of Pegasus versus, the Compass, you actually bleed more in Pegasus. You have 2.7 times the risk of bleed, which is 170% higher in Pegasus trial. But if you compare with, say, Compass, it's increased only 70%. So much higher risk of bleed in this chronic segment subgroup if you're looking at dual pathway in terms of ticagrelor. But if you're looking at Carisma or Capri, maybe you don't increase, it's just increased by 17% but then there is no benefit. So I think you'll have to take that risk of slightly higher bleeds with more CV benefits. And I think most important parameter in choosing a therapy is mortality. If anything reduces death, that supervenes and supersedes everything else. Just like I talk about sometimes about SGLT2 and empagliflozin and EMPA-REG trials, I just tell them, I mean, it doesn't matter whether it's coming from where, from the kidneys or the brains or from suicidal tendencies. I don't know. If it's reducing death, I think that therapy has to be at the center of the management in a patient. So nothing matters more than life. If the patient's life is increased by any therapy, the mortality goes down. I think everything else is a soft parameter. So if the patient's therapy, which is life, is improved with Compass trial, I think I'll stick with dual pathway inhibition in a chronic segment rather than go by DAPT strategy. Though there is a slightly higher risk of bleeding when you compare with clopidogrel, but there is no benefit. And compare with it, Pegasus, there is lesser bleed compared to Pegasus arm and Compass arm. So that way, probably I'll go with DPI.
So I would say that rivaroxaban is beating ticagrelor, by that way. But I think that's
a separate debate on some other day. But so that's a separate debate in a different segment. So I think we also need to look at the kind of patients that were involved. They were not MI patients, so we need to understand if the patient is not MI and has undergone a revasc Compass, that is the Compass kind of a patient. If you had a transmural MI, that's like a Pegasus like a patient. So I think you'll have to make that choice. But let's restrict to the topic today, which is the Compass trial. So which talked about a chronic polyvasculopath, multivessel disease, high risk ischemic burden patient, where DPI is definitely superior than SAPT or DAPT with the chronic regime kind of a therapies.
Right, sir. Thank you so much, sir, for answering the questions. I would like to just tell the team, who are listening, this was the highest recorded attendance of any CME that we have done. More than 80 people were logged in at a given point of time. And I would really like to thank the Gujarat team. Neerajji, if you're there online, if you can extend the thanks to sir as well for such a wonderful talk and enlightening us with the topic. So Neerajji, over to you.
Yes, sir. Thank you very much, Dr. Kamal Sharma, for valuable time and valuable insights on rivaroxaban. And I'm sure our attendees, all the doctors who have attended it, they are very
I think we lost Neerav's voice.
Neerajji, yes, आपकी आवाज चली गई है. I thought.
okay.
Yes.
Sir, thank you very much for your valuable insights about rivaroxaban, and thank you very much for your valuable time. And all the attendees, we have circulated your CV as well as contact details also. So anytime any doctor requires any guidance of Dr. Kamal Sharma, you can contact them. He is one of the best cardiologists I have ever interacted with. Thank you very much, sir.
Thank you so much, sir. Thank you.
Thank you. Thank you.
Right.
Bye-bye.
Thank you. Thank you.
Bye, sir. Bye.
Bye.
Thank you very much to all the attendees for your valuable time.